Hello, my name is Dr. Dan Lozier, and today we're going to be talking about one of my favorite subjects, the cardiovascular system. So what do you say? Let's get started. All right, this slide pretty much says it all. What's the number one killer of Americans? Cardiovascular disease. 647,000 die every year from cardiovascular disease. That's approximately one individual every 37 seconds. I am always blown away by this number down here and I think that number is actually conservative. I think it's closer to 90% or maybe even a little higher than that. But let's say conservatively, between 80 and 90% of all patients who have cardiovascular disease, it's preventable. Their cardiovascular disease is preventable with lifestyle management and changes, whether that's stopping smoking, exercising, eating a healthier diet. So think about that. The number one killer of Americans, going on 750,000 individuals, and in 80 to 90% of the cases, it's completely preventable. The next few slides you can review on your own. They're a review of the anatomy and physiology of the heart, pictorial of the heart. We went over, I know, some of this in a college lab when we talked about the cardiac and the cardiac electrical conduction. But we can go through a brief review of the blood flow of the heart, because that's important. So deoxygenated blood is going to return back to the heart via the inferior and the superior vena cava. That blood is then going to enter into the right atrium, pass through the tricuspid valve to the right ventricle. From the right ventricle, it's going to pass through the pulmonic valve into the pulmonary artery and go to the lungs, where it's going to pick up oxygen. From the lungs, the blood is going to return to the heart through the pulmonary vein, where the blood is going to be dumped into the left atria, and then is going to pass through the bicuspid or mitral valve to the left ventricle, and then is going to pass through the aortic valve and through the aorta to the rest of the body. Okay, when we're talking about the primary role or function of the cardiovascular system, which is to deliver oxygen and nutrients to the cells and tissues and organs of the body, let's not forget that the cardiac muscle itself is an organ made up of cells and tissues. So not only is the heart responsible for oxygenating and providing nutrients to all the other organs of the body and removing waste products, it's also responsible for supplying oxygen and nutrients and removing waste products from the myocardium itself. And when we're talking about the supply of oxygen to the heart itself, the myocardium, there are two major coronary arteries. They are the left coronary artery here, and then the right coronary artery here. You may have heard the term the widowmaker. The widowmaker is the left coronary artery, and that's because it supplies blood to the much larger left ventricle. Right ventricle smaller because it only has to pump the heart from the right ventricle to the lungs, whereas the left ventricle has to pump blood throughout the entire body. We talked about the electrical conductivity in the conduction system of the heart in college labs, so go ahead and review that material. When we talk about how does the heart know how fast to beat, how does it know how hard to beat, how does the vasculature know whether to be vasodilated or vasoconstricted, that's all part of the autonomic nervous system's responsibility. Two primary systems in the autonomic nervous system are the sympathetic nervous system and the parasympathetic. Sympathetic nervous system is, remember, the fight or flight. That's when the body will release epinephrine and norepinephrine And also that's from a hormonal, from a neural standpoint, the alpha adrenergic and beta adrenergic receptors are going to be stimulated by the epinephrine and norepinephrine. And we'll talk about that when we get to the cardiovascular disorders. And likewise, the parasympathetic is going to receive signals also from the autonomic nervous system. And the primary hormone there is acetylcholine. And what that is, that's going to divert oxygen from other organs in the body, divert it to the stomach for digestion of the foods, absorption of the foods, and then also the autonomic nervous system is for the repair and building and maintenance of tissues in the body. These are the receptor sites that we talked about that the sympathetic nervous system, the epinephrine and norepinephrine are going to stimulate different receptors. There's the alpha receptor sites. The alpha 1 are in the heart, alpha 2 are in the arterioles. So when the alpha 2 receptor sites are stimulated by the epinephrine, that's going to cause vasoconstriction. That's when you're going to want to increase the patient's blood pressure. And beta 1 receptor sites are in the heart, so that's when we'll be speeding the heart rate up and speeding the force of contraction of the heart. And beta 2 will be in the lungs. And then not talking about it as much, but there's a dopaminergic effect as well. So when the autonomic nervous system detects that there's a decrease in circulating oxygen and maybe again the increase in CO2, it is going to release epinephrine and norepinephrine. Epinephrine and norepinephrine are going to find those receptor sites that I just showed you on the previous slide. What that's going to do is that it's going to increase the heart rate. It's going to increase the force of contraction of the heart. It's going to cause vasoconstriction, so it's going to get the blood to the organs of the body under higher pressure. The problem is that the sympathetic nervous system, if it is chronically kicking in, that's going to wear the heart down. So if the heart is continually having to beat faster and beat harder through constricted vessels, it's going to increase the amount of oxygen that the heart needs because it's a muscle like any other one. So the harder the heart works, the more oxygen it's going to consume. And the harder the heart works, that's called the workload. It's going to increase the workload of the heart when the sympathetic nervous system is stimulated. And then on the other side, the parasympathetic, acetylcholine is going to be released, and that's going to decrease the heart rate. And it's also going to cause vasodilation of the vasculature. So if we're decreasing the heart rate, we're decreasing the blood pressure, the amount of resistance the heart's going to encounter when pumping the blood, and that's going to decrease the workload of the heart. And it's also going to decrease the oxygen consumption of the heart. Now, hopefully, as we talk about this throughout the slides, it's going to become more familiar. I'm going to continue to reinforce this whole process throughout this presentation. In order for you to understand the cardiovascular system and cardiovascular disorders, it's imperative that you understand cardiac output. So what is cardiac output, otherwise represented as CO? It's the measurement of the amount of blood pumped by each ventricle over 1 minute period of time. The autonomic nervous system that we talked about is going to control the heart rate. It's going to control the force of contraction. It's going to control the amount of resistance the heart's going to encounter by whether there's vasodilation or vasoconstriction. And it's going to control that based upon whether or not the cardiac output is meeting the oxygen and nutrient demands of the body. If by the receptor sites and the increase in CO2, decrease in O2, decrease in pH, if that's the signals that the heart is getting, it's going to need to increase the cardiac output in order to meet the oxygen and metabolic demands of the body. So what does the cardiac output comprise of? This is the very important formula. So cardiac output, which is the amount of blood leaving the heart over 1 minute period of time to meet the oxygen and nutrient requirements of the body. What determines the cardiac output? Well, it's the heart rate times the stroke volume. The heart rate typically is 60 to 100 times a minute, and the stroke volume is the amount of blood that leaves the heart with each beat. So would it not make sense that in order to determine how much blood leaves the heart in 1 minute, we'd want to know how many times is the heart beating and how much blood is leaving the heart with each of those beats. So again, the stroke volume is the amount of blood that is ejected from the ventricles with each beat. So the normal cardiac output is between 4 and 8 liters per minute. So let's just say that if the patient's normal heart rate is 80 beats per minute, and the normal amount of blood that leaves the heart with each beat is going to be 100 milliliters, and then so 80 times 100 is 8,000. All right, very good. Milliliters. The cardiac index, good to know. The cardiac index is basically taking the cardiac output, but also taking into consideration how big the patient is, the square foot of their body surface. Is this a big patient, a little patient? And so the cardiac output and measurement per square foot of body surface. The cardiac index, so it's a more specific measurement of cardiac output. Okay, so if we look again, here's that formula. Most important cardiac output is heart rate times the stroke volume. The stroke volume has two components as well. Stroke volume, remember, is the amount of blood that leaves the heart with each beat. How much blood leaves the heart with each beat? Well, the determinants are going to be the preload, which is how much blood is in the heart just prior to contraction. That's the preload. The second is going to matter is the afterload, which is the amount of resistance that the heart is going to encounter as it pumps blood out of the heart. So how constricted are the vessels? Are the vessels obstructed by atherosclerosis, as an example? So the amount of blood leaving the heart is going to be determined by how much blood is in the heart, the ventricles, just prior to systole or contraction, and how much resistance is the heart going to encounter. So what would affect my cardiac output, or the amount of blood leaving the heart over 1 minute period of time? The heart rate. The faster the heart rate, like when you really get up there in the heart rate and you're over 120, 130, etc., the faster the heart is beating, the less filling time is going to be with the ventricles. And so the other thing would be the slower the heart rate is going to decrease your cardiac output, and you may not have sufficient amount of oxygen and nutrients that are meeting the cells and tissues of the body. So as it says down here, when stroke volume decreases, then the cardiac output will be decreased as well. Okay, we're continuing to dissect the formula for cardiac output. We said cardiac output equals heart rate times stroke volume. We covered heart rate in the previous slide. Now let's look at stroke volume. Remember, we said that the stroke volume is made up of preload and afterload. The preload is the amount of blood that's in the ventricles just prior to systole or contraction. So if the preload is high, let's say, why would the amount of blood be high? Well, let's say we have heart failure. Let's say we have fluid volume excess. Let's say we have a over production of the antidiuretic hormone. We have the renin-angiotensin system that's kicking in and causing retention of sodium and fluids. That would all cause an increase in the preload. So the heart is used to managing a certain amount of blood. So the left ventricle, for example, is usually used to this amount of blood that's leaving with each beat. And it's going through let's switch hands. So it's going through the vasculature, and it's a normal amount of blood. Whoop, and the normal restriction of the vasculature. So with each beat, well, let's say that now we've increased the volume of blood, and now we have the same vasculature. Oh, so it's, oh, son of a bee. Oh, son of a bee. So there's more blood trying to pump through the vessels. So in order for the heart to meet the metabolic demands or the cardiac output, it still has to get a certain amount of blood out. Now we've got an increase in volume, and which means we're going to have more resistance trying to push all that volume through the vasculature. The afterload is the amount of resistance or pressure. So just think the resistance is the blood pressure. What would cause a higher blood pressure? Vasoconstriction from the sympathetic nervous system, causing the adrenergic receptors to cause vasoconstriction. Atherosclerosis is also going to cause an increase in the resistance. So the the heart again is going to try to respond to the sympathetic nervous system, and it's going to say, hey, you know what, you're not meeting the oxygen demands. You're going to have to beat harder. You're going to have to beat faster. You're going to have to beat through constricted vessels. We're going to trigger the renin-angiotensin system, which is further going to cause vasoconstriction and further cause an increase in preload. So, the heart keeps sending signals to got to meet the cardiac demand, got to meet the cardiac output demand, and eventually it's going to work itself to the point where it wears out. At first it'll get enlarged like any muscle, but then it's going to get enlarged and stretched to the point where it's efficient, and that's when you're going to have your heart failure. Okay, so other factors that affect cardiac output is the contractility, which is the force of contraction. That's the inotropic. Inotropic is the force of the contraction. As I said before, the sympathetic nervous system is going to say, hey, heart, beat harder, beat faster. Well, in beating faster and beating harder, as I said, that heart muscle is going to eventually get stretched to the point where it's not going to be effective anymore. And that we would term ventricular hypertrophy, or in left ventricular hypertrophy enlargement. So this is an important term, workload. So workload is the amount of effort required of the heart to meet the oxygen and metabolic demands of the body over a 1-minute period of time. Workload is the amount of effort required of the heart to meet the oxygen and metabolic demands of the body over 1-minute period of time. So the harder the heart has to work to meet the oxygen and metabolic demands of the body, the higher the workload. Okay, so a patient that, for example, that has cardiovascular disease, if the heart is receiving signals from the autonomic nervous system, the sympathetic nervous system is saying, hey, beat harder, beat faster through restricted vessels, that's going to increase the workload. Well, on a short-term basis, that's okay. Let's say if we have a multiple, systems that are affected from a motor vehicle accident. Well, that increase temporarily of the workload to meet the cardiac output demands could keep that patient alive, but over a chronic, prolonged period of time, that's not good for a cardiovascular patient. The longer the workload, the quicker that heart is going to wear out. So the clinical manifestations of cardiovascular disease, and that includes all cardiovascular diseases that we'll be talking about, from hypertension to heart failure to myocardial infarction to coronary artery disease, angina. Clinical manifestations are included in this slide: fatigue, chest pain, dysrhythmias, AFib, VFib and VTAC all have the potential to cause mortality. Dyspnea, which is difficulty breathing, even though we're not talking about the respiratory system or diseased lungs, the body is going to react to a decrease in circulating oxygen, and it's going to tell the lungs, hey, you need to increase the rate and increase the depth of your respiratory effort. So it's going to manifest itself as dyspnea, even though the lungs are fine. Tenderness in the calf and leg pain is going to have to do with peripheral vascular disease. That term is claudication. Dizziness and syncope, and that could happen from orthostatic hypotension as an example. Fluid retention and edema with heart failure, and abnormal heart rates and blood pressures. All right, so let's look at the cardiovascular disease now. These diseases are the ones that are going to impact cardiac output in a patient. Coronary artery disease, valvular disease, MIs, hypertension, PVDs or peripheral vascular disease, which includes both peripheral arterial disease as well as peripheral vascular disease. And then when there's actual damage from an infarction, from that a cardiomyopathy, which is a disease of the heart. Not to be confused with cardiomegaly, which is an increase in size of the heart, and hypertrophy, which we talked about, where the heart is working, and it's like any muscle, it's going to get larger, but eventually it gets stretched to the beyond the point where it's efficient. So we'll talk about each of these individually in upcoming slides. This is just a summation of all the different diseases that will impact the cardiac output. Remembering that cardiac output is the amount of blood that leaves the heart over a 1 minute period of time. And the autonomic nervous system is going to determine that cardiac output based upon meeting the demands of the body for oxygen and nutrients and removal of waste products. Hypertension. Hypertension is sustained elevation, and the key term is here, sustained elevation. Not transient, but sustained, of the blood pressure on 2 separate occasions while the patient is seated. In adults, the parameters that qualify a patient as being hypertensive is a systolic of 140 millimeters of mercury or greater, and or a diastolic of greater than 90 millimeters of mercury. So 140 over 90 and above is considered to be hypertensive. We'll still use that less than 120 over 80 is normal. So between 120 over 80 to 140 over 90, that's pre-hypertensive, in that range. Clinical manifestations, and now we're specifically talking about hypertension, not just cardiovascular disease in general, but hypertension, often called the silent killer, because a lot of people are walking around and don't realize that they have hypertension. Fatigue, headaches, shortness of breath, and chest pain are the other typical clinical manifestations of a patient with hypertension. What is the cause or etiology? The couple of primary causes. Primary hypertension, it's just hereditary. We don't know of a specific cause. It isn't something that the patient is doing wrong, like not getting enough exercise or not maintaining appropriate weight or dietary habits. So it can be caused from heredity, water and sodium retention, stress can cause primary hypertension on a patient. And then look at this, the altered renin-angiotensin mechanism. We're going to be talking a lot about this in the days to come in Nursing 103, and including in lab if we haven't already talked about it. So the renin-angiotensin system is also a compensatory mechanism that is triggered by the autonomic nervous system when a patient's cardiac output is not meeting the oxygen and metabolic demands of the body. So in addition to the release of epinephrine and norepinephrine, the nervous system can also stimulate the release of the renin-angiotensin system. So when renin is released in response to a decrease in the body's ability to meet the oxygen and metabolic demands, when renin is secreted, it causes the production of angiotensin 1. Angiotensin 1 then comes into contact with a angiotensin converting enzyme. When that converting enzyme binds to angiotensin 1, it turns into angiotensin 2. Angiotensin 2 long term is not good. Angiotensin 2 is a powerful vasoconstrictor. It also stimulates the release of aldosterone, and aldosterone triggers sodium and water retention. So let's think about that. Again, in a motor vehicle accident, when the patient is bleeding out, boy, that renin-angiotensin system is going to be a good thing. It's going to help maintain the blood pressure on our patient to perfuse the major organs. But if we have a patient that has underlying cardiovascular disease, what we're doing with the renin-angiotensin system is increasing not only the preload, but also the afterload. The preload is increased by the release of aldosterone, and the afterload is affected by angiotensin 2 being a powerful vasoconstrictor. So high blood pressure causes the heart to work harder. All right, so the blood pressure is the amount of resistance that the heart is encountering when trying to eject blood out of the ventricles. So hypertension could be caused by vasoconstriction, angiotensin system. It could be caused by atherosclerosis buildup, or both. Hypertension could be caused by an increase in the workload, an increased volume of blood trying to get through the lumens of the vasculature. As the heart works harder to pump sufficient amount of blood to meet the demands, if it's pumping more blood against more resistance to meet that cardiac output, then the heart is going to work harder. When the heart works harder, that increases its workload. When we increase the heart's workload, we're increasing the heart's oxygen consumption and oxygen demand. That's an important point. As the heart works harder to meet the cardiac output demands over 1 minute at a time, to meet the body's metabolic and oxygenation demands, the heart is going to work harder, and it's going to consume more oxygen, and it's going to demand more oxygen. And remember that there may be a time with cardiovascular disease that the demand of oxygen may go up, the consumption of oxygen may go up, but the supply of oxygen to the myocardium might be decreasing. So that's a bad combination. How do we manage hypertension? Lower sodium. Remember, water follows sodium. So if we decrease our sodium, we're going to decrease the water retention, which is going to decrease our preload, which in effect is going to decrease our afterload, which is going to decrease the workload, which is going to decrease the oxygen demand and the oxygen consumption. Reduce cholesterol and fat, because cholesterol and fat are going to contribute to atherosclerosis, which is also going to increase the amount of afterload, or the amount of resistance. Maintaining appropriate electrolyte balance. Smoking cessation. There we go again. Smoking cessation. We keep talking about it over and over again. We need to stop smoking, and we need to severely restrict the amount of individuals that are smoking. Restriction, obviously, and that is a choice, but make it a difficult choice to make. Based upon taxes, paying for healthcare, etc. We now know that smoking causes significant health problems, and the individual should be responsible for their choices should they choose to smoke, even though they know the myriad of healthcare problems that it causes, expensive healthcare problems as well, and moderation with alcohol intake. So when we're talking about pharmacologic intervention for hypertension, What are we going to do? What kind of mechanism of action or pharmacologic action? Well, one type might decrease the circulating blood volume. How would we do that? That would be a diuretic. Decrease the systemic vascular resistance. That would be a vasodilator. That could be alpha adrenergic receptor antagonist. So we'll look at the individuals. Diuretics we talked about, which is going to increase the excretion of urine, which is going to decrease the circulating blood volume. Adrenergic inhibitors, both beta as well as alpha adrenergic inhibitors. And we'll talk about each of the drugs in particular. Direct vasodilators like nitroglycerin, nitrobid, isorbide dinitrate. Angiotensin and renin inhibitors, ACE inhibitors. ACE inhibitors. What does that stand for? So an ACE inhibitor is an angiotensin converting enzyme inhibitor. Remember, if angiotensin 1 does not come in contact with a converting enzyme, it won't become angiotensin 2. And angiotensin 2 is what we're trying to block, because angiotensin 2 is a powerful vasoconstrictor, and it also triggers the release of aldosterone, which causes the sodium and fluid retention. And calcium channel blockers. Calcium channel blockers directly will work on the smooth muscle in the arterioles. And by blocking the calcium uptake into the smooth muscles, you're going to inhibit the smooth muscles' ability to contract. So in effect, what you're doing is reversing vasoconstriction and causing vasodilation through calcium channel blockers. We'll talk about these. We're just getting warmed up here, and we're going to reinforce these, and I'll let you know what medications that I want you to really concentrate on. Diuretics, furosemide is Lasix is an example. ACTH, which is hydrochlorothiazide. Torsemide, which is a very potent diuretic. These three, however, not only are they going to promote excretion of urine, but you're also going to lose potassium as well. So these are not potassium-sparing diuretics. When we have an increase in urine excretion, we're also going to lose potassium. So with these, it is important that we monitor our potassium level, which should be, remember, between 3.5 and 5.1. 3.5 to 5.1. All right. There are diuretics that are what we call potassium sparing. That's aldactone and triamterene. So aldactone would probably be the one that we would most see and in this situation. So potassium sparing, non-potassium sparing. Sometimes you will see both of these in combination. You will see a non-potassium sparing that is prescribed to your patient, and also a potassium sparing, so that they may get two in the same day. Nursing interventions make sense. If you're giving a diuretic, which is an antihypertensive, you got to check the blood pressure on the patient. As a general rule, the parameter is when the blood pressure drops below 90 millimeters of mercury as a systolic, you're going to want to question whether or not you give that, and you may, depending upon whether there's a parameter that is written in the order or not, you may want to contact the MD at that point and let them know the blood pressure and your concern with administering it. Monitor daily weights. We would hope that if particularly for those patients that are retaining fluid, that their weight will decrease as their increase in urine volume decreases. Assess the patient for signs and symptoms of dehydration. Oh my gosh, we're giving a diuretic in order to decrease hypertension. We're doing that by decreasing the preload and the afterload, by decreasing circulating fluid volumes. And gosh, if we give too much and we have too much urine output, now all of a sudden we've gone from a problem with hypertension to a problem with dehydration. Remember, for every intervention, there's a correlating set of potential complications. And complication of a diuretic A potential complication is dehydration, and we've talked about fluid volume deficit and what those clinical manifestations are already in college lab. Report if the patient complains of dizziness, fatigue, and muscle cramps. Evaluate the medical efficacy. Is it working? Is our blood pressure decreasing, or not? Which is what it was administered for or prescribed for. Direct action vasodilators, which would decrease hypertension by relaxing the smooth muscle in the peripheral vasculature, particularly in the arterioles, as we block the vasoconstriction. Then it causes vasodilation, which is going to decrease the resistance that the heart's going to encounter, which is your afterload, and it's going to optimize cardiac output without increasing workload, oxygen consumption, and oxygen demand. Some examples of direct vasodilators are nitroglycerin, nitrobid, isosorbide mononitrate, previously in a slide. So pretty much we're going to be looking the same thing. We're going to hold it or question whether or not we give it when the blood pressure and systolically is below 90. Sit the patient up slowly because we have vasodilators and they could have a syncope episode until the body kind of levels out. So the same thing with standing them, because we got to be careful that we're not giving a nitroglycerin or a direct vasodilator. Patient stands up quickly to answer the phone, which is not close by. They get a syncope episode, they fall and they break their hip or worse. So the patients do complain of dizziness, fatigue, visual disturbances, and headaches, which are examples of hypotension. All right, and then is it working? Is the patient's hypertension decreasing as a result of giving the direct vasodilators? Alpha adrenergic. Alpha, just think arterioles. Alpha adrenergic blockers. So if you block the alpha adrenergic receptors, you're going to, this is a real fancy term, reduce peripheral sympathetic tone. Basically what it's going to do is that it's going to inhibit vasoconstriction. So in effect, what we're doing is causing vasodilation in this patient. So alpha adrenergic are going to block vasoconstriction in the arterioles. And examples are Cardura, Catapress, Hytrin, and Regitine. Maybe less so knowing these medications specifically as much as knowing what an alpha adrenergic blocker will do. What is the pharmacologic action of an alpha adrenergic blocker, which is going to be to decrease your afterload or the amount of resistance. And if you decrease the amount of resistance, it's going to decrease the workload of the heart and the oxygen consumption of the heart. Check the blood pressure, like all blood pressure medications, same parameter, less than 90. Monitor for orthostatic hypertension, same thing, hypotension, that we don't want to sit the patient up slowly or have them stand slowly. The last thing we want is to have a orthostatic hypotension and syncope episode, and the patient falls and breaks a hip or has a head injury or worse. Orthostatic hypotension, remember, is defined by a change in the systolic blood pressure of 20 millimeters of mercury or greater. Systolic, when the patient goes from sitting to standing or lying to sitting, and or a decrease in 10 millimeters of mercury for the patient's diastolic. Decrease in 20 millimeters of mercury from sitting to standing or lying to sitting, and or 10 millimeters of diastolic. Same thing, these are clinical manifestations of hypotension. And is it working? Is our blood pressure actually decreasing on our patient? Those are alpha adrenergic. Now we're looking at beta adrenergic blockers. So beta adrenergic are in the heart, alpha in the arterioles. So the beta blockers, if we block those, they're going to decrease the heart rate, which is going to increase the filling time. It's going to decrease the amount of oxygen consumption and demand. And so if we decrease the heart rate, that's also going to help to decrease the blood pressure. And that's not all beta blockers are going to decrease blood pressure as well as decreasing the heart rate, but they all are going to decrease oxygen consumption. All right, so the beta blockers, which decrease the heart rate, and some of them will decrease the peripheral vascular resistance. That's going to optimize or increase the cardiac output, and it's going to decrease oxygen consumption, decrease workload of the heart. In all of these cardiovascular diseases and managing all of these diseases that we're talking about, the primary role is to preserve the myocardium. Preserve the myocardium. The higher the oxygen demand, the higher the workload, the faster the heart's going to wear out. So preserve the myocardium. How do we do that? We do that by optimizing cardiac output, but at the same time by managing workload and oxygen consumption and oxygen demand of the heart. Because if the heart is working harder, workload, at a time when it's decreased in its oxygen supply, then the heart myocardium itself, those cells and tissues, are going to be affected and weakened by the lack of oxygen. And if they weaken, then the heart muscle is going to weaken, and that's really going to damage your cardiac output, or not damage, but limit your cardiac output. Okie doke. When we're talking about beta blockers tend to end in LOL. Beta blockers, atenolol, propranolol. Those are tend to be your beta blockers ending in LOL. Okie doke. So same thing. Oh my goodness, what are we going to do? Check the heart rate this time. So these medications are going to decrease the heart rate. So if we give a medication like metoprolol, which is going to decrease our heart rate, we want to hold that medication if the heart rate falls below 50. I would be a little nervous if it fell below 60, but some of these might be the parameters that are written in the order that the doctor is prescribing. Check the blood pressure. Some of the medications, the beta blockers, will not only decrease the heart rate, but also will cause vasodilation. So in those, for example, certain medications that we're going to check both the heart rate and the blood pressure. Sit the patients up slowly, orthostatic hypotension. These are the clinical manifestations, once again, of hypotension. And with beta blockers like metoprolol, we do not want to just suddenly stop that medication. We have to wean the patient off the medication. If we're giving that patient metoprolol as an example for a prolonged period of time, and then we just stop it, we don't wean the patient off or gradually decrease the amount until they're off of the medication, they can have what's called rebound hypertension, where that hypertensive episode can just come roaring back. Also with metoprolol, one of the side effects, particularly in men, is sexual dysfunction. So if a patient is receiving metoprolol and they suddenly come to you and tell you that they want to stop taking this medication, they don't think it's working for them or it's the right medication, you may want to dig a little deeper, and perhaps what you're finding underneath that with some good therapeutic communication is that what they're most concerned with is the sexual dysfunction side effect that's associated, with metoprolol. Calcium channel blockers. We did mention. So calcium channel blockers are going to decrease the myocardial contractility, or the force of contraction. It's also going to um, block the coronary arteries and arterioles from constricting. And so remember, there's smooth muscle. There's smooth muscle, and the smooth muscle is going to constrict as a result of the sympathetic nervous system, releasing epinephrine and norepinephrine. So calcium channel blockers are going to dilate those arteries and arterioles and allow greater blood flow and oxygen flow to the heart. So an increase without using calcium channel blockers, if the sympathetic nervous system is saying, hey, it's increasing the contractility and it's increasing the vascular resistance, that's going to increase the workload of the heart, which is going to increase the oxygen consumption and demand, and eventually it's going to cause heart damage. A lot of the calcium channel blockers are going to end in PINE. Nifedipine. Another one is amlodipine. Amlodipine. So look for that PINE, just like beta blockers end with LOL, blol, atenolol, metoprolol. Channel blockers oftentimes will end in PINE, amlodipine, nifedipine. Verapamil and diltiazem are also examples. All right. Check the heart rate. There we go again. If it's going to affect the heart rate and decrease the heart rate on a patient, we're going to hold that medication if it's less than 50 beats per minute. Since it is not only working on the heart rate, but also decreasing the vasoconstriction, then that is going to cause a decrease in the blood pressure. So with some of these medications and calcium channel blockers, we're not only going to check the heart rate and hold it if it's too low, but we're also going to check the blood pressure and hold it if it's too low. Sit patients up slowly, same thing. And let's see, not so much this one. Here we go, the same thing. That is clinical manifestations from hypotension, and evaluate if the medication is affected. Is it controlling the blood pressure of the patient? Okay, ACE inhibitors. ACE inhibitors, gosh, are we still talking about hypertension? Yeah, we are. Good news is that if you understand these medications for hypertension, it's the same medications that we're going to give with a number of other cardiovascular diseases in the future. So you'll have these reinforced. It's just a good medication to know about, ACE inhibitors, and in particular the one that we most often see is lisinopril. So ACE inhibitor, think lisinopril. ACE inhibitor is going to once again convert the angiotensin 1 from becoming angiotensin 2. That's good for a patient with cardiovascular disease and hypertension, because angiotensin 2 is both a powerful vasoconstrictor, which increases your blood pressure, and then it also, angiotensin 2 causes the release of aldosterone, which causes sodium and water retention, which causes an increase in circulating fluid volume. So ACE inhibitors work to both block and decrease preload and afterload. Preload from blocking aldosterone, afterload from blocking angiotensin 2, which is a powerful vasoconstrictor. That would be a good point or two to remember there. Both decreases preload as well as afterload, and lisinopril is an example. Okie doke. There we go. Check the blood pressure. Again, less than 90. We didn't say anything about heart rate. We just talked about vasoconstriction and circulating fluid volumes. I&O and daily weights on your patient. Make sure that you're checking your patient's renal function, because we're talking about the angiotensin, renin-angiotensin aldosterone system, which has to do with the kidneys. Dizziness, nagging cough, just a funny symptom. Don't know why. But some patients that take lisinopril as an example, they've got a cough. It sounds like they have an asthmatic cough. It's a spasmodic cough, and it just comes and goes at different times, and it's really irritating for the patient. Again, checking your renal status for your patient, and is it working? Is our patient's blood pressure lowering? Okay, so let's look at what we have here. So hypertension management, lower the sodium level because water follows sodium and we want to control the preload in our patient. Exercise is an excellent way to decrease your blood pressure. Exercise also increases the number of high density lipoproteins, which carry plaque and fats away from the body. Weight control measures, cholesterol and triglycerides. So diet, smoking cessation, absolutely, and alcohol in moderation. And I know I mentioned it in the respiratory lecture, but if I didn't mention it here, one of the top 3 risk factors for a patient developing cardiovascular disease, which is the #1 killer of Americans, one of the top 3 risk factors is cigarette smoking. Bruh. All right, complications of a patient. What happens long term if hypertension isn't controlled on cardiovascular disease? And so hypertension is going to lead to coronary artery disease, which is going to lead to left ventricular hypertrophy or enlargement. Eventually, if that isn't reversed, you're going to continue, remember, with coronary artery disease, you're going to decrease the amount of oxygen supply to the heart at a time when the heart is working harder. So you have an increase in your workload. At the same time, you have a decrease because of hypertension and coronary artery disease. You're going to have a decrease in oxygen supply. Increased workload coupled with decreased oxygen supply, that's going to result in heart failure because you're going to decrease the amount of oxygen reaching the cells and tissues of the myocardium. They're going to weaken, and you'll have your hypertrophy and then your heart failure. Look at the size of this heart silhouette. Good gracious me. That is a huge, huge heart. That's a great picture of heart failure. And then renal failure. So hypertension is going to cause cardiovascular disease directly, but it's also going to cause renal failure by affecting the glomerular filtration rate. And now the patient starts out with hypertension and it's developed into coronary artery disease, borderline heart failure, and then now we have renal failure, so chronic kidney disease. So all around bad news. Okay, we said that hypertension will contribute to coronary artery disease. What exactly is coronary artery disease? If you remember early on when in this presentation we showed the slide of the heart, and we showed that the heart also needs to be oxygenated. It's an organ, and it's comprised of thick muscle. So the right coronary artery and the left coronary artery supply oxygen to the heart. As we look at cardiovascular disease such as hypertension, when the heart is having to work harder to meet the cardiac output demands for appropriate oxygenation and nutrition to the body. Remember, when the heart works harder, it consumes more oxygen, it demands more oxygen because of the increase in the workload. Well, if you have coronary artery disease, you are blocking or inhibiting oxygen supply to the myocardium itself. So if the autonomic nervous system is saying, hey, we need to increase the cardiac output by increasing your heart rate, increasing the amount of circulating volume, increasing the force of contraction, increasing vascular resistance or blood pressure, that's going to significantly increase the workload of the heart, increase the oxygen consumption of the heart. And great, if we have coronary artery disease, even though we have an increase in demand and consumption of oxygen, we've got a decrease in supply. So if we have an increase in workload and a decrease in oxygen supply, that's going to lead us very quickly to heart failure. All right, so coronary artery disease is an abnormal narrowing of the lumen of the coronary arteries. Remember, there's the right coronary artery and then the left coronary artery. The left coronary artery, when blocked, sometimes is referred to as the widowmaker. All right, very good. And when you have a buildup of plaque in the arteries, that's called atherosclerosis. So you can, atherosclerosis is typically peripheral. It's not just in the coronary arteries, but it can be throughout the body where you have this buildup. It can also be in the not only the coronary arteries, but the carotid arteries as well. So if you have severe enough atherosclerosis and decrease of flow of oxygen to the brain, that's when you have your cerebral vascular accident or your strokes. So atherosclerosis basically is a result of an over consumption of fats in the body, and the body will try to remove excess fat, and it does that by the high density lipoproteins, but working contrary or against high density lipoproteins or the low density lipoproteins, they're going to pick up the excess fat and deposit it in the major arteries of the body, such as the coronary artery, the renal arteries, the carotid arteries. So atherosclerosis, excess fat that over time, when it's deposited in the arteries, is going to harden. And that's when we have kind of the layman's term of the hardening of the arteries. Okay. So the three major risk factors for a patient developing coronary artery disease are hypertension, hypercholesterolemia. Sometimes you might see that hyperlipidemia, so that includes cholesterol and triglycerides, and cigarette smoking. There it is, cigarette smoking. Boom. What are we doing? Modifiable risk factors from non-modifiable risk factors. So I want you to be able to differentiate between these two. Modifiable is things that the patient can change. So they can change the hyperlipidemia through their diet. They can help to control their hypertension by their weight and exercise and diet. Smoking, they can eliminate smoking. Diabetes, particularly what we're talking about, modifiable type 2 diabetes. This is a good slide to know. Modifiable versus non-modifiable risk factors for cardiovascular disease. Obesity, boy, we talked about that in GI. Stress and inactivity. So patient needs to be able to control their stress more efficiently, and a sedentary lifestyle is going to lead to cardiovascular disease. So the patient needs to create and maintain a healthy exercise pattern in their life. So where those are unmodifiable, where those were modifiable, the previous slide, these are unmodifiable. That means that the patient cannot control these. Unmodifiable risk factors the patient can control are their age, their sex, and their race and heredity. So those two slides are good. Be able to know and to recognize and apply the differences between modifiable risk factors versus unmodifiable risk factors for cardiovascular disease. How is it managed? Again, everything that we're doing is going to be targeting our goal of preserve the myocardium, preserve the myocardium. The harder the heart has to work, which means the increase in the workload to meet the oxygen and metabolic demands of the body, the more oxygen consumption it has. And remember, coronary artery disease it means that they're going to have a decrease in oxygen supply because of the occluded arteries. At the same time that the oxygen has an increase in demand. Increased demand and consumption at a time when there's decreased supply is a recipe for heart failure. And so what we want to do is to optimize cardiac output, but not at the expense of heart failure. So we may actually have to at sometimes decrease the cardiac output in order to preserve the myocardium, because if the body keeps responding to signals to increase cardiac output at a time when that increased workload is not going to be supplied by sufficient oxygen, we're going to exacerbate the heart failure, and as we said, over 600,000 deaths every year. Okay, so decrease the oxygen demand. How do we decrease the oxygen demand? Well, we can decrease the heart rate. We can decrease the amount of resistance. We can decrease the preload. All of those things are accomplished through the medications that we just talked about relative to hypertension. And so by preserving the myocardium, we're going to decrease mortality and morbidity. In other words, we're going to allow patients to live longer and healthier if we can manage the effects of coronary artery disease, if we can preserve the myocardium. What are some clinical manifestations with coronary artery disease? Well, let's think about that. So the heart's working harder, the heart is consuming more oxygen, but the cells and tissues of the myocardium are not receiving sufficient oxygen, and so they begin to become ischemic from a lack of oxygen reaching the myocardial cells. What would we think that would look like? Well, chest pain. Angina, pain, pectoral muscles, pain in the chest muscles. The definition of angina is that it's a transient pain. This is an important slide to know. What is angina? Angina is typically a result of coronary artery disease. What is coronary artery disease? It's an unusual increase in plaque in the coronary arteries, which causes a hardening, which increases the blood pressure, which decreases blood supply to the myocardium. When a patient that has coronary artery disease, particularly at a little bit past the early onset, that when that patient exerts themselves, they are going to experience this chest pain. The other thing important, that angina can also be caused by spasm, by the coronary arteries spasm as a result of decrease in oxygen. So that also causes angina. But what I want you to remember is that angina caused from coronary artery disease, it's transient. It comes and it goes. It's predictable. All right, it's predictable, and that the patient gets to the point where they have a pretty good idea of what amount of effort, what amount of exertion is going to trigger that angina. So it's predictable. It's also transient. It comes and goes, and it is reversible. It is reversible. So this is the key word right here. It's transient. It comes and goes. It isn't always there on your patient. And it can be reversed with rest and nitroglycerin. Rest and nitroglycerin. All right. Now, when we have a decrease in the amount of oxygen reaching the heart to meet the oxygen demand, that's called ischemia. So this is not prolonged ischemia. This is transient ischemia from an increase in effort on the patient. When we have a normal EKG, we're going to have our P, our Q, our S. This is in lab. We learned this in lab. And then we're going to have our T wave. This is what a normal is going to look like. So we have our P, your Q, our S, and your T wave. When you have transient ischemia, that is going to manifest itself by an inverted T wave. So you're going to have in that situation your P, your Q, R, S, and this time you're going to have an inverted T wave. An inverted T wave. All right, don't confuse that. When you have a myocardial infarction, you're going to have prolonged ischemia, not transient, and it's going to be an elevated T wave, ST wave. All right, very good. So stable angina is a transient chest pain caused by the ischemia, which is where the patient is exerting themselves. Can also be caused by spasm, arterial spasm. It usually lasts 3 to 5 minutes, and it's reversible. It's relieved with rest and nitroglycerin. It's not prolonged ischemia. It doesn't last 15 minutes, 30 minutes, and longer. It can be reversed. The patient oftentimes, as I said, knows the amount of exertion that's going to trigger it, and with rest and nitroglycerin, it's going to go away. Unstable angina, on the other hand, is the new onset of chest pain. They didn't know perhaps that they had, coronary artery disease. They didn't know that they had, a propensity towards angina. All of a sudden, they have this new onset of chest pain that they're real concerned about. It's not predictable. It's not reversible, and so it's unpredictable and not reversible with rest and nitroglycerin. That's unstable angina. And then there's another kind, Prinzmetal's angina, which is caused by coronary spasms and coronary artery spasms, and that occurs at rest, which is interesting. Not so much with this one are we concerned about as being able to differentiate stable angina from unstable angina. And when we get unstable angina, we're looking at the next, upcoming slides, which is acute coronary syndrome. What medications might we give for coronary artery disease resulting in myocardial ischemia and chest pain? Well, platelets and anticoagulants. So if we have a decrease in blood supply, blood's trying to rush through those occluded, blocked coronary arteries that are full of atherosclerosis. That blood's going to rush in there under high pressure, and it's going to try to push through, and you're going to have some potential for stasis of blood, or the blood banging back and forth there. And when you have that, you have the opportunity for platelet aggregation. So patients that have coronary artery disease, to decrease that formation of blood clots in their aspirin and Plavix, and a low molecular weight heparin. So aspirin and Plavix, antiplatelet. Beta blockers, remember, are going to decrease the heart rate, the excitability of the heart, the conductivity of the heart. And some of the beta blockers, like labetalol, are not only going to do that, but they're also going to cause some vasodilation as well. So beta blockers, depending upon which one, is going to decrease heart rate, force of contraction, the electrical conductivity. By decreasing heart rate and force of contraction, we're going to decrease the oxygen demand. We're going to decrease the workload of the heart. And in some of them, like I said, you're actually going to cause some vasodilation, which will further decrease the workload of the heart. Calcium channel blockers are going to decrease the force of contraction of the heart, that inotropic effect, and they're also going to cause vasodilation. So by decreasing the afterload, and by decreasing the force of contraction, we're going to decrease the oxygen consumption, we're going to decrease the workload of the heart, and we're going to help preserve the myocardium, because we know that there's a decrease in oxygen supply. ACE inhibitors, lisinopril, good example. So beta blockers would be metoprolol, good example to know. Calcium channel blockers, amlodipine, good example to know. ACE inhibitors, lisinopril, good example to know. And ACE inhibitors are going to block angiotensin II formation, which is going to cause vasodilation, so it's going to decrease your afterload, and it's also going to release aldosterone, which is going to, so it's going to block the release of aldosterone, which in turn will decrease the circulating blood volume. So ACE inhibitors like lisinopril are going to decrease both preload and decrease afterload. And if I'm getting specific on the medications, then you may want to know those. Nitrates, nitroglycerin, just direct vasodilators, and morphine. Morphine is a medication that we're going to give a patient when they have significant angina and chest pain. Alrighty, these are just some examples of nursing diagnoses for your patient that has coronary artery disease. Okay, I think that when we move forward here, it's good to know that we're taking a different step here in severity. So we're going to change in severity from having hypertension, coronary artery disease, angina, to a life-threatening situation called acute coronary syndrome. Remember what a syndrome is, all right? A syndrome is an abnormal accumulation of signs and symptoms. What are the signs and symptoms in acute coronary syndrome? Well, they're going to be chest pain, EKG changes, which may indicate prolonged ischemia that looks like on an EKG that the patient has an elevated ST waves. A decrease in cardiac output, and the patient is going to potentially be very anxious. Okay, good to know. These are the two cardiac disorders or concerns that fall under acute coronary syndrome. Think about acute coronary syndrome. So acute coronary, acute coronary, like acute coronary attack. Wow, we got to figure out right now what's going on before we lose this patient. That's how significant it is. Acute coronary syndrome is made up of two diagnoses. It's unstable angina. And unstable angina, oftentimes, even though it's prolonged ischemia, there might not be sufficient, there might not be excessive myocardial damage at this point. So the unstable angina falls under acute coronary syndrome. We got to figure it out. There is a prolonged ischemia, but not sufficient enough myocardial damage to elevate the S and the T wave on our EKG rhythm. And the other is the ST elevated MI. So we said that you have your P, you have your QRS, and you have your T wave. And they typically will come down to this isoelectric line here. They'll come down to this isoelectric line. What happens so the P wave leaves the line, comes back to the line, QRS leaves the line, comes back, T wave leaves the line and comes back. When we have a ST elevation in an MI, here's what happens in that situation. So you have your line here. Sorry, it's hard to draw with the mouse. So you have your P wave comes back to the line. Now when you have your QRS, as opposed to it coming back down the line, your QR and now your S is going to stay elevated, and your T is going to be elevated off of this line right here. All right, so as opposed to it looking P, QRS, and T, you can see this elevation. That's what we're talking about, elevation right here. That's the ST elevation. That's indicative of prolonged ischemia that's resulting in significant myocardial damage. Even though here we're beginning to see some myocardial infarction, it's not significant enough damage or thick enough myocardial damage to elevate the ST, but this one is. So what's going to happen if we don't revascularize here and get that arterial blood flow to the myocardium? It's going to end up leading to an ST elevated MI, which means that there's significant myocardial damage. So myocardial ischemia is just a decrease in perfusion of oxygen to the myocardium itself. So you have a decrease in perfusion, not only oxygen, but also nutrients. And remember that the oxygenated blood is coming to the myocardium via the right coronary artery and the left coronary artery. And if you have a significant enough narrowing or blockage of the coronary arteries, that's going to cause a decrease in perfusion of oxygen to the myocardium. Well, let's look at it. So what would be a narrowing or a blockage is going to be as a result of your plaque buildup. So you have your plaque buildup and you have your hardening of your arteries, and the blood is trying to flow through. You could have a complete blockage if that plaque builds up to the point where it actually occludes blood flow, or you might throw a big old clot, and that big old clot is going to come in here, and that clot is just going to occlude the lumen of the artery to prevent blood flow. Okay, good slide. Here we go. This is the difference between this slide and for angina pectoris. Acute coronary syndrome, remember it's emergent, occurs when ischemia is prolonged. Ischemia is not transient, it's prolonged. It's not immediately reversible. That's the key term. And it can result in that ST elevation that we talked about. It can result in unstable angina. So sometimes what we have going on isn't always just an occlusion from atherosclerosis. So when we have atherosclerosis build up in our patient, I said that the atherosclerosis builds up and then it begins to harden. Sometimes what happens is with that hardening and that atherosclerosis buildup is this plaque here, because of the high pressure of the blood flowing through, this plaque is going to break away from the lining of the arterioles or the arteries. It's going to pull away and break away. When this plaque pulls away and breaks away, what it's going to do, number one, you're going to have a big hunk of plaque that's going through the vasculature. That's not good. But the other thing, when it pulls away, that's going to cause some bleeding. And when it pulls away and it results in some bleeding, the body's going to need to clot that. So the body's going to come in and it's going to form a big clot here where it just tore away from the wall of the artery, and it's going to wall it off and it's going to form a clot. Well, it formed a clot, which is nice, but remember, now we're still under significant tension, hypertension, and so that blood now rushing through there harder and harder may actually cause now this blood clot to break free. And now the blood clot has broken away. And as it gets further and further into the myocardium, into the myocardial vasculature, it's going to, just like the pulmonary emboli, eventually it's going to reach a point where that blood clot is going to stop, and everything that is being fed distal to that, all the rest of this heart, is not going to get perfused with oxygen. So depending upon how big that clot is, may determine just how severe that myocardial infarction is. It may be immediate, an immediate death. It may be something that registers in chest pain and elevated ST, and they can go in there and try to dissolve that clot. Or if it is, occlusion of plaque. So we have this occlusion of plaque. Remember this one? When you have the occlusion that is caused by plaque buildup. So this is the lumen here, plaque buildup, plaque buildup, plaque buildup, plaque buildup. Now all of a sudden you severely decrease the opportunity for blood to flow through. There's very, very minimal opening. So sometimes when you get a 90% or greater occlusion, you get severe chest pain, you get ischemia, you get myocardial damage. So this is when they would come in and they would put a catheter in here, and then they would try to just push all of that plaque back. So they try to just smash that plaque up against the wall, and that is called a percutaneous coronary intervention. All right, and more to come on that. So, gosh, I said it was an emergency. Remember, it's an emergency. Time is muscle. Time is muscle. The most important thing with acute coronary syndrome, we know we've got prolonged ischemia. We know that the patient is beginning to suffer some myocardial damage. We've got to get them to cardiac cath lab, and we've got to revascularize that patient. We've got to either put something in, an angioplasty that's going to compress the plaque up against the walls and reestablish vascularization and maybe put a stent in place, or we're going to give a thrombolytic to dissolve the clot. But either way, we're going to either have to reestablish vascularization to the myocardium, or we're going to have severe myocardial damage that the patient might not be able to survive, or it may be sufficient enough heart damage that that patient will not be able to meet the cardiac output demands of the body because they have destroyed a significant amount of myocardial muscle. So a myocardial infarction is a prolonged ischemia resulting in death of the myocardial tissue, death of the muscle itself. Signs and symptoms: pain lasting greater than 30 minutes, oftentimes will manifest in its chest, but has been known to radiate down the shoulder, the neck, and the jaw of the patient. Nausea and vomiting. The patient has difficulty breathing. Why? Because they're lacking oxygen, because the heart muscle is shutting down. Severe apprehension and anxiety, just like with a pulmonary emboli, sweating, diaphoresis, pallor, a change in their normal coloration, and just severe weakness. How do we diagnose this? Well, taking a history on the patient. Do they have a history of hypertension, smoking, hypercholesterolemia, coronary artery disease, any hereditary factors? Friend of mine, 70 years old, just a couple weeks ago, had a major surgery. He had a quadruple bypass, and he had 4 major coronary arteries that were occluded. He was not aware of it. His dad, however, died in his 40s of a massive heart attack, and his mom had a coronary stent placement when she was in her 70s. So, he had the hereditary, but he didn't have any of the clinical symptoms. And he did smoke early on, a pipe for many years, but that was 40 years ago. EKG changes to help diagnose an MI. ST elevation, again, we talked about that. QRS and is normal, so your P wave is normal, your QRS, and then your normal T wave. But in the event that the patient has a myocardium, then what you're going to see manifested is the P wave returns to the line, the QRS doesn't return to the line, it stays elevated, where it should have come down and returned back to this line here. So here's your elevation. Here's your elevation, the S. So Q, R, S, and T wave, ST elevation. Abnormal Q waves, don't have to worry about those as much, what they might look like, but just know that you may see abnormal Q waves. That's all you need to know. Abnormal Q waves may show up on an EKG with an MI. Cardiac enzyme changes. Let's look at cardiac enzymes that might be elevated. Let's see. I believe it's on an upcoming slide, but let's go ahead and talk about that. So there are 2 cardiac enzymes that are elevated. I know it's going to come up with diagnostics later. The 2 cardiac enzymes which are released in the body as a result of significant myocardial damage are troponin and CKMB. So there's going to be blood work that is going to be drawn looking for an abnormal levels of the 2 cardiac enzymes of troponin and CKMB, which is indicative of myocardial damage. In the acute situation of a patient that has a myocardial infarction, if that is a blood clot that has broken free and is occluding the coronary artery, we have the opportunity, just like a pulmonary emboli, to inject a fibrinolytic like TPA or streptokinase, and that will dissolve the clot. Lytic, lysis. Thrombolytic will thrombus, lyse the thrombus, so dissolve the thrombus and reestablish vascularization. That patient is going to need anticoagulation therapy, heparin, warfarin, could be a heparin drip, at that time, antiplatelets. Aspirin, a lot of times a patient in the field is given aspirin, and that's still part of um, the management of a patient pre-hospital care, to give them aspirin when they are managing them for myocardial infarction. The other antiplatelet is Plavix. Oxygen, certainly the patient is dyspneic, the patient is decreasing their oxygen supply because of the bad pump with myocardial damage. Pain control, this is interesting. So morphine, look at this. If I see a listing of medications, morphine not only controls pain, but it also lowers the heart rate and the blood pressure on a patient. That's why it's such a good medication. Not only great pain control, but also lowers heart rate and blood pressure on a patient. Remember, lower the blood pressure, lower the heart rate, decrease the oxygen consumption, decrease the oxygen demand, decrease the workload of the heart, preserve the myocardium. A lot of times the myocardial infarction is going to trigger a patient to go into a lethal dysrhythmia. So the two lethal dysrhythmias we learned about in cardiac lab, in college lab, are VTAC and VFib. Ventricular tachycardia and ventricular fibrillation are the two dysrhythmias that can be triggered with a myocardial infarction, and patients will and can die from either one of these two lethal dysrhythmias. If the patient has had some significant myocardial damage, that myocardium that's left may need to take over some of the workload. So we may give medications that are going to increase the amount of contractility of the heart, or the force of contractility, positive inotropic. Digoxin is an example of a positive inotropic drug, where it will actually increase the force of contraction. Remember that digoxin from your college lab requires sufficient amount of potassium in the bloodstream. If there's not sufficient amount of potassium in the bloodstream, digoxin will not be absorbed in the myocardium. It's just going to build up and build up in the vasculature. And if it builds up to a certain level, we have what's called digoxin toxicity, or dig toxicity. Continuing with anticoagulation therapy, please know this slide here and be able to recognize these parameters. So for heparin, APTT, or partial thromboplastic, let's see, I'm drawing a blank here. So time, partial thromboplastin time, is going to be elevated when your patient has heparin. So if the normal is 28 to 36 seconds, what you want to see in a patient that is receiving heparin is that you want to see the patient's APTT, or partial thromboplastin time, elevated, okay? 1.5 to 2.5 times this range. So know that, be able to recognize that, because I might ask you a question and say, this patient is receiving heparin therapy. Is this within the therapeutic range? So therapeutic range, what would you take? 25 times 1.5, 25 times 2.5, and that's the low range, and then 38 times 1.5 to 2.5. PT and INR, particularly we're going to look at the INR. Less than 1 is a normal INR, and an INR level of 2 to 3 is therapeutic. So remember, we want an increase in the time it takes to clot. We want to increase the partial thromboplastin time. We want to increase the international normalizing ratio. That's going to decrease the risk of clot formation. So let's remember that anticoagulants do not dissolve the clot. They reduce they prevent, the existing clot from getting bigger and subsequent clots from forming. And then, so heparin, Coumadin, and then antiplatelets, which would be your aspirin and Plavix that we talked about. There's a normal platelet count. Gosh, for every intervention, there's a correlating set of potential complications. So if you have a normal 150 to 450,000, you give an antiplatelets. Now you've dropped it below 50,000. Gosh, now your patient has gone from a risk of blood clots to a risk for bleeding. So all of those have to be monitored very carefully, and it's our responsibility to monitor those. And the thrombolytics, again, that dissolves the clot. That's if we can get in there in time, and we can give the patient streptokinase, we can give the patient TPA, we can dissolve that clot and reestablish vascularization, preserve whatever myocardium hasn't been affected. Okay, what do we need to monitor for a patient that is receiving anticoagulants? Well, you know these. You need to assess for bleeding of the patient. This patient is going to be much more susceptible. Even pulling out an IV may cause prolonged bleeding in a patient. If this patient hits their head or bangs their arm on a side rail, as an example, they could have significant bleeding. So one of the most important things in managing a patient with an anticoagulation order is to provide for a safe environment, particularly that patient is a fall risk where they might really injure their head and end up with a head bleed. Monitor whatever they happen to be receiving, your PT or PTT or INRs, your platelet count on your patient. And concurrently, do not give the patient aspirin and NSAIDs at the same time they're receiving anticoagulants, because you could have an exaggerated effect of preventing clots, which might actually predispose the patient to bleeds. If the patient's on Coumadin or warfarin, avoid green leafy vegetables. Why? Because the antidote to too much warfarin is going to be vitamin K. And why do we not want to give green leafy vegetables? Right, because they contain vitamin K, and they're going to reduce the effectiveness of the patient receiving warfarin and Coumadin. All right. What medications for a patient that has suffered a myocardial infarction? Beta blockers, we talked about those. Calcium channel blockers, review what they do. Nitrates, diuretics. Why are these meds indicated? Because we want to preserve the myocardium. As example, in this with a beta blocker, we're going to decrease the contractility or the force of contractions, decrease the conduction of the heart. So we will be slowing the heart rate down. Some of the beta blockers, labetalol, are also going to cause vasodilation. Calcium channel blockers are going to slow your heart rate down. They're going to decrease the force of contraction. They're going to cause vasodilation. Nitrates, direct vasodilators, diuretics are going to decrease circulating fluid volume. So in all of these, what we're doing is going to be optimizing the cardiac output, but not at the expense of workload. So we're going to preserve the myocardium that we have. We're going to decrease by these medications. We're going to decrease the heart rate, decrease the preload, decrease the afterload. In effect, that's going to decrease the workload, which is going to decrease the oxygen consumption and preserve the remaining myocardium. All right, there we go. There we go. Again, all of this gets back to that formula, cardiac output. Everything we've talked about is related to this formula. Cardiac output is heart rate times stroke volume. Okay, so sometimes we have to go a step further than just pharmacologic agents such as thrombolytics and anticoagulants, and including antiplatelets, that we might have to go in there and perform a surgical intervention. The surgical interventions are going to allow for revascularization of that included coronary artery. If the coronary artery is blocked by a buildup of atherosclerosis and you've got 100% occlusion, if the coronary artery is blocked by a emboli that has broken free from a blood clot, and lodged. We need to find out what it is through cardiac catheterization. Is it just a buildup? Not just, but is it a buildup of plaque, or is it a blood clot we're dealing with? So we take that patient, get them very quickly. Acute coronary syndrome, one of the first things we're going to do is get them to cardiac catheterization to find out where is the vascularization being blocked and what is causing the block. So you cardiac cath, you take a catheter and you put it in the patient's leg. You can go in the artery or vein in the patient's leg, depending upon which side of the heart you're working on. You will feed that catheter and they'll be able to see it they'll be able to follow it on the screen, and then they're going to find out where is that occlusion. So one of the things that with the catheter that they're going to do is they're going to release a dye, and that dye is going to show them where the blockage is, because everything that is distal to that blockage is not going to be perfused. Not going to be perfused. Actually, I tried to make that in black. So you can see the vessels, but there's no perfusion there. Why? Because you've got a big clot right here, or you've got a big obstruction from atherosclerosis. So put the catheter in, put the dye in there, and see exactly where, that's called an angiogram, exactly where the occlusion is and what the occlusion is. And then you determine if it's a blood clot and it's within a certain number of hours from the onset of your symptoms, you can give your thrombolytic. That thrombolytic is going to dissolve that clot. It's going to dissolve that clot, and it's going to reestablish vascularization. If it is a major occlusion from atherosclerosis and coronary artery disease and a buildup and hardening of plaque, then they're going to take this catheter, and what they'll do is they will inflate a balloon. So they're going to inflate a balloon, which is going to push the plaque up to the outside of the arterial wall. They can place a stent in there, and what will that do is that it's going to reestablish vascularization, so that everything is going to be now vascularized distal to what that occlusion initially was. So the process of taking your cardiac cath and feeding the catheter and putting the catheter up to where that occlusion is, and you're going to blow up that balloon, which is going to push the plaque against the wall, and then leave a stent in there. That's called a balloon angioplasty with stent placement. Atherectomy is where they're going to take a catheter in, put it past where that buildup of atherosclerosis is, and then they're going to pull it out. And when they pull it out, they're going to pull that, break up that atherosclerosis and pull that away from that spot. Sometimes we kiddingly call that like a rotor-rooter, where they put the catheter in, push it past, work it past, and then they'll open up these prongs and then pull it back towards them. And by doing that, they're also going to pull out the plaque. And not really going to worry about this one as much. Coronary artery bypass grafts, if they've put that angiogram in there and they've determined that there are occluded vessels from atherosclerosis, and in fact there's more than two, then if there are, and this one says if there are two or more vessels that are occluded, then they're going to choose not to do the percutaneous intervention, but they're actually going to have to do open heart surgery, where they're going to have to open the patient's chest, put them on a heart-lung bypass, and go ahead and create grafts that are going to bypass where the patient's occlusion is. They can use synthetic veins, they can use the saphenous vein, they can use existing veins in the abdominal area. And so what they'll do is let's say this is the aorta right here, and this is where the occlusion is, and this is the vasculature here that goes past the occlusion. What they will do is that they will actually maybe take that graft and put it on the outside, put it distal to where the occlusion is. And that I recognize is just an awful picture. So let me try this a little bit differently. If this is your vasculature that goes up here, and then your vasculature branches off to feed different sections of the heart, And this is the occlusion right here. So everything here is going to be perfused all the way up until the occlusion, but nothing past the occlusion. So what they'll do is they can take that graft. If this is my aorta, they can take a graft, they can sew it into the aorta, and then they can bring that graft down. And so they'll put the graft distal to the occlusion and sew it in there. And then now you've just increased the perfusion back for the patient. Pardon me. All right. So 2 or more vessels, or let's say that they tried the angioplasty, they've tried the stent placement, and it's not working on the patient, then they may have to go to a coronary artery bypass graft. Excuse me, complications of myocardial infarction, ventricular arrhythmias, VTAC, VFib, heart failure. So if this is my heart and you have damage to that heart, this significant portion of the heart is damaged, and it's irreparable. What you have done is you've just removed all this muscle here. And so now the heart's going to try to pump blood, but it's certainly not going to have the same level of cardiac output because you've got a decreased mass of muscle, because this has all been infarcted and is dying. So only this part of the heart is going to be able to now contract, which is going to decrease your cardiac output. And so that's, if you have a decrease in cardiac output as a result of myocardial damage and that inability of this part of the myocardium to beat, because there's an insufficient cardiac output, we're going to call that heart failure. So heart failure is an insufficient cardiac output to meet the oxygen and nutrition demands or metabolic demands of the body. Cardiogenic shock, again, when it's so significant a infarction that now we just cannot perfuse the rest of the body. And now, because there's all this infarction here and you have such limited amount of healthy myocardium left, you're just not going to be able to perfuse the major organs of the body. And once they begin to have decrease in oxygen and nutrients, they're gonna begin to weaken, and they're going to die, and then you're going to have your multi-organ failure, which is eventually going to lead to death. Or you just might have cardiac arrest, just the heart just stops beating. We call that asystole. Okay, heart failure. In heart failure, could be as a result of coronary artery disease, where we just overwork the heart and stretch the heart beyond its capacity and its efficiency to contract. Or we could have heart failure from myocardial infarction, where we've damaged such a significant amount of myocardium that it can't eject enough blood to meet the demands of the body, or significant enough cardiac output decrease. So again, heart failure can be from coronary artery disease and just overworking the heart and stretching the heart because of the lack of oxygen supply, or it could be heart failure as a result of a major myocardial infarction, and you've just infarcted or destroyed significant amount of the myocardium. All right, this is what we just mentioned, what heart failure is. Hypertension, coronary artery disease, and myocardial infarction can all cause a decrease in sufficient amount of cardiac output to meet the metabolic and oxygen demands of the body. Heart failure, oh boy, acute heart failure, one of the hallmark signs of heart failure is pulmonary edema. Pulmonary edema is an abnormal accumulation of fluid in the lung tissue and or the alveoli. Don't get that confused. Make sure you know your definitions. Don't get it confused with pleural effusion or pneumonia. Pulmonary edema is fluid in the alveoli or lung tissues. Remember, one of the hallmark signs is pink, frothy sputum. But you're going to see patients going to be in severe respiratory compromise, wheezing, crackles, which you don't want to hear, tachypnea with the respirations greater than 30. Here's that pink frothy sputum. And then patient that has chronic heart failure that they're living with, they're just going to be continuously fatigued, dyspneic, and have peripheral edema. Oftentimes, not maybe necessarily your pulmonary edema, but peripheral edema. Left-sided heart failure and right-sided heart failure. You'll see LAHF and RHF, or systolic and diastolic, or both. Systolic heart failure is failure of the left ventricle to eject sufficient blood. Diastolic is failure of the left ventricle to be able to fill fully, and because the muscle's stiff and it can't relax and allow for filling. And sometimes you have both. Okie doke. Right-sided heart failure. Right ventricle is the one that's affected, and the right ventricle, when it's affected, blood's going to back up from the right ventricle to the right atrium to the inferior and superior vena cava. So you might see your jugular vein distension and also your peripheral edema, because the heart is not pumping the blood back up from the extremities to the heart. Most oftentimes, right-sided heart failure is caused by left-sided heart failure. So what do we need to do? Gosh, we need to increase the force of contraction with whatever myocardium we have left. Digoxin is great. Oftentimes we're going to see digoxin and Lasix given together for a patient in heart failure. Not so much digoxin as we used to see, but we always used to see that combination. So remember, with digoxin, you're going to have to monitor the potassium levels. If there's insufficient potassium, then the digoxin is not going to have the ability to uptake into the myocardium, and the levels are going to get higher and higher in the bloodstream to the point where you have dig toxicity. Beta blockers, very good, which for heart failure, so that's going to slow your heart rate down. It's going to decrease the force of contraction. It is going to, in some situations, cause a vasodilation, all of which is going to decrease the oxygen demand and the workload on the heart. So diuretics, Lasix, hydrochlorothiazide, aldactone. Remember to check the potassium level on those that are not potassium sparing. ACE inhibitors, lisinopril. Lisinopril is going to decrease the preload and the afterload, which is going to decrease the workload of the heart, and is going to decrease the oxygen consumption and help to preserve whatever myocardium we have left. Whenever we have an increase in cardiac output and we have blood that's pooling, you have the increase in risk for clots. Just like in atrial fibrillation, when the atria is just fibrillating back and forth and you don't have sufficient movement of the blood from the atria to the ventricles, that blood bouncing around in there also has a risk for clotting. Long-term management of patients with heart failure: reduce the workload of the heart. So increase the cardiac output and contractility, but not at the expense of causing more extensive heart failure. And so this is just a real balance between increasing workload, but make sure that you're monitoring the oxygen supply to the heart. If you increase the workload at a time when there's insufficient oxygen supply, you're just going to exacerbate that heart failure. And you think of all these, that's why, the number one killer of Americans is cardiovascular disease. Sodium and water retention, you're going to decrease. That's going to decrease the preload, which in effect is going to decrease the afterload, which is going to decrease the workload, which is going to help preserve the myocardium. All right. Good one to know here: activity intolerance. Remember, we said this patient is fatigued, fluid volume excess. When we have heart failure, you're going to have fluid volume excess, and that could manifest itself in peripheral and/or pulmonary edema. Impaired gas exchange from the pulmonary edema. If you have an abnormal accumulation of fluid in the alveoli, that air and the gases are not going to exchange through the water that's building up in the lungs. Not water, but vasculature, that increase in fluid in the alveoli. Excuse me. Okay, very good. So activity intolerance, that patient's going to be fatigued, so we want to make sure that we cluster the care on that patient. All right, we're getting close to the end here. You guys are doing great. And it's a cool slide. Peripheral vascular disease so we're talking about cardiovascular disorders. We've been up to this point mainly focusing on cardiac disorders. So let's look at peripheral vascular disease, PVD, peripheral arterial disease, and peripheral venous disease. Peripheral arterial disease is going to be, so think about that. You have oxygen that's going down to the lower extremities. And if you have a decrease in blood supply and blood flow, because you have maybe significant atherosclerosis built up, and so you have a decrease in perfusion because of atherosclerosis. You have weakened pulses, pedal pulses. Um, your skin color is going to change. You're not going to be nice warm feet. The feet are going to be cool. You're going to have decreased capillary refill where greater than 3 seconds. This is interesting that, remember, hair follicles are live cells and they need oxygen. So when you have a decrease in oxygen to the lower extremity, the hair is not going to grow. So they have these shiny legs. And then this is a good one. When a patient has decrease in oxygen flow to the lower extremities, with exertion is going to increase oxygen demand. But we have a decrease in supply. Because we have an occlusion, we have a decrease in blood supply. And so with exertion, that we increase the oxygen demand at a time of decreased oxygen supply. Just like we have angina or chest pain, we're going to have pain particularly in the calf, in the lower extremities, with ambulation, and that's called claudication. And it'll come and go depending upon the effort of the patient. So oftentimes you might see it as intermittent claudication. What's that caused by? Same thing that coronary artery disease is caused by, an abnormal buildup of plaque in the arterial vasculature. Okay, laboratory and diagnostic studies that we want you to look at. Cardiac enzymes, we mentioned earlier. The two cardiac enzymes that I want you to learn are CKMB and also troponin levels. These are the two most sensitive indicators of myocardial damage, so good ones to know. And know that we're going to take them serially, or not just one, but we may take one and then get another set 4 hours later, another set 6 hours later. Why would we do that? Because each of these are going to peak and drop off at different times. So the troponin is actually going to be the first one to rise, and then it's going to be starting to fall at about the time when the CKMB spikes. So we take them serially because we want to make sure that the first time we got this and all we saw was troponin increase, well, we didn't wait long enough, but when we did it 6 hours later, guess what? We saw a troponin increase, but we also now seeing the CKMB increasing. And just nice to know, not need to know. Again, the two that I want you to know are the CKMB. They're the most sensitive, and this one is the first one to rise, the troponin. Blood tests, when you have cardiovascular disease, particularly in a myocardial infarction, you're going to have elevated white blood cell count and an increase in your erythrocyte sedimentation rate. This is from the inflammatory response from the myocardial damage. Erythrocyte sedimentation rate is an indication of the sediment that is left over from the breakdown of red blood cells. So red blood cells have their normal life cycle, and so you're going to see healthy red blood cells, but then you're also going to see red blood cells that are beginning to break down, and that's what the sediment is. So when you have an inflammatory response of significance like a myocardial infarction, for whatever reason, the red blood cells, a number of them are going to break down prematurely. So you're going to have a increase in this erythrocyte or red blood cell sediment that's floating around in the blood. So an increase in erythrocyte sedimentation rate, otherwise known as the ESR. Okay, lipid levels, yes. Hypercholesterolemia, hyperlipidemia. ProBNP, good to know. ProBNP is a blood test. Or sometimes you just might see it BNP. BNP or proBNP, brain natriuretic peptide, that is an indicator of heart failure. BNP is an indicator of heart failure. So if they send what blood test is the might you expect to see ordered on a patient to determine whether they're in active heart failure, it's the BNP. BNP. Okie doke. EKG, gosh, good slide to know. We've talked about these, be able to differentiate. Ischemia is that T wave inversion. It's upside down. It is transient ischemia. Infarction, ST elevation, is prolonged ischemia, which is resulted in myocardial damage. Ischemia, T-wave inversion might be your angina pectoralis, which is predictable and reversible, and it's a transient ischemia. Where a ST elevation is indicated of prolonged ischemia resulting in myocardial damage. All right. Chest x-rays are good for determining if the patient has left ventricular hypertrophy, if they have cardiomegaly, if they have pericardial effusion. Not so much that we're going to be looking at these tests and asking you to do anything with them. But again, pulmonary edema is indicative of heart failure. Pleural effusion is an abnormal accumulation of fluid in the pleural space. Pericardial effusion is an abnormal accumulation of fluid in the pericardial sac surrounding the heart. And not so much at this point in this lecture, knowing calcium. CAT scans, nice to know, not a need to know. Stress test or to determine if the patient has latent coronary artery disease. Remember, coronary artery disease does not manifest in angina pectoris until the patient has exerted themselves. So when they want to find out just how much exertion is required to produce myocardial ischemia that causes angina, well, they're going to do a stress test. So they're going to put that patient on a treadmill and increase the exertion and monitor the patient to see just how much exertion is required and what exactly is happening, what level of ischemia is happening with exertion. Don't have to know this. There are other tests that are out there. This is a nuclear medicine test. Excuse me, post MI to determine the extent of the myocardial damage. Same with this one here, echocardiogram. The TEE is transesophageal echocardiogram. A normal echocardiogram, they're going to be able to see the front of the heart and the sides of the heart, but they can't visualize the back of the heart with an echocardiogram. A transesophageal echocardiogram, actually the patient is going to swallow a catheter that has the transducer on it, and then that's going to be able to then bounce the waves off the back of the heart to see if there's myocardial damage on the back side of the heart, or the posterior of the heart. Isn't that cool? You don't have to really know that, but for any testing purposes, but you might see that on your patient. MUGA scan, same thing, is just to determine another type of scan to determine myocardial damage. Holter monitor, I do want you to know, Holter monitor is something that the patient might be hooked up to where the patient's having some echocardiogram, is having some chest pain. Maybe some dyspnea, and when the patient goes to the doctor's office, the EKG is normal, but the doctor said, well, maybe I'm just not picking it up right now, maybe something is triggering it. So the Holter monitor is when the cardiologist will send the patient home on EKG monitoring for 24 hours or longer, depending upon what is ordered. So what I want you to know is the patient will be hooked up to an EKG leads, and there's going to be this monitor that they're going to have to take with them called the Holter monitor. And the patient is going to be instructed, or the patient education, is that the patient should resume their normal day-to-day activities, even those activities that might cause stress or chest pain, such as going to their grandson's soccer game, or riding a bike, or walking on a treadmill. So they don't want to restrict their activities. They want to undergo their normal activities. They will also keep a diary so that when they feel those feelings of chest pain, dyspnea that brought them to the cardiologist, they can record the date and the time of day, and what activity that they're currently involved with when those symptoms happen. That way the cardiologist can go back to that date and time, know that activity, look at the EKG during that time frame, and see whether or not there are any EKG changes. So the patient should normal day-to-day activities, and also keep a diary, and don't get in the shower when you're hooked up to the EKG machine and the Holter monitor. Good slide to know. Okay, just a very brief snippet here on anemias. Irregardless of which anemia you may be looking at, whether that's pernicious anemia or just decrease in red blood cells, hemoglobin and hematocrit from hemorrhage, as an example, sickle cell anemia. What all anemias have in common is that they have a decreased capacity for red blood cells to carry oxygen. And remember that the red blood cells are the primary carriers of oxygen to the cells and the tissues of the body. So that's all I really wanted you to know about that. And certainly if we have a decrease in oxygen carrying capacity, we're going to have a decrease in oxygen reaching the cells and tissues of the body. So those clinical manifestations are going to be fatigue, weakness, shortness of breath, pain, headache, and none of that, I'm sure, is anything that would be surprising to you. That's all I want to say right now about anemia. Different peripheral vascular studies to determine whether the patient has peripheral arterial disease, also whether the patient has a deep vein thrombosis. And we talked about that with with respiratory system. I don't have to know this one right now. Cardiac catheterization, that was that percutaneous coronary intervention, the PCI, that they're going to employ when you have acute coronary syndrome, where they're going to take them to cardiac cath, and they're going to insert that catheter through a vein or an artery and feed it up into the heart. They can take measurements of the output of the heart, the pressures of the heart. They can release a dye for an angiogram to see what vessels are occluded. They can also, through cardiac catheterization, they can go in and they can do the balloon angioplasty, where they're forcing that plaque up against the arterial wall, putting a stent in there, delivering a thrombolytic to dissolve a clot. My goodness. Okay. With cardiac catheterization, hold metformin before the procedure to 48 hours after. Why? Metformin in combination with a cardiac cath can cause an acidosis. And certainly if you're putting something into the vessel, a major vascular vessel, you want to hold anticoagulants so that when you pull that out, that the patient doesn't bleed. Well, as this slide indicates, it's hard to believe we've reached the end. I want to thank you so much for the privilege of presenting to you today. And I hope that you fall in love with the cardiovascular system as I have. And as always, stay strong and be healthy. And we'll see you next time. Thank you.